Welcome to the next in the KDIGO Genetics in CKD webinar series. Today's episode is episode 9, the role of polygenic risk scores in nephrology. My name is Bob and I'll be the moderator today. A big thank you to our audience for submitting questions ahead of the webinar today. Today's presentations will be followed by a questions and answer period. Our presenters today are Krzysztof Kiryluk, Columbia University, United States, and Matthias Wuttke, University of Freiburg in Germany. Without further ado, I'll turn things over to Krzysztof. Go ahead.
So I would like to thank KDIGO for inviting me to talk about polygenic risk scores and their potential applications in nephrology. I am interested in the development of polygenic risk scores for various forms of kidney disease, and my research centers on the genetic basis of kidney diseases. I have no relevant disclosures. And this is the outline of my talk. In the first part of my talk, I will say a few words about the genetic architecture of common complex traits and how these concepts relate to kidney disease. In the second portion of my talk, I'll describe polygenic risk scores. I'll go over some basic concepts, definitions, and limitations of the risk scores. And then I will go over several landmark papers, really concentrating on an example of coronary artery disease. And in the last part of the talk, I'll describe some of our most recent work on the polygenic risk score for chronic kidney disease. So let's get started with basic concepts on the genetic architecture of human disease. So from the genetic perspective, we think about human diseases in two categories: monogenic diseases or Mendelian traits that are determined by rare variants, inherited variants with relatively large effect that tilt the balance of health towards the disease state. These variants typically have relatively high penetrance, so individuals carrying these variants have a high probability of developing a given trait. On the other end of the spectrum, we are dealing with complex traits that are typically thought to be determined by multiple common genetic variants with additive effects on the risk of the phenotype. Some of them will interact with environment, and cumulatively, these common variants tilt the balance of health and disease towards the disease state, but individually, these variants have relatively small effects. So the main kind of workhorse behind the discovery of genetic factors for common complex traits has been genome-wide association study design. And in this design actually requires a large-scale recruitment of a group of cases and controls. These individuals get genotyped with DNA chips, or perhaps are being genome sequenced nowadays across the entire genome. Typical DNA chips contain 1 to 2 million SNPs across the genomes. These are variants that are common in various populations, and they're used as a backbone for more dense imputation of common genetic variation, typically up to roughly 10 million SNPs. In a typical genome-wide association study, then the frequency of various alleles at these typed or imputed loci is compared between cases and controls to identify risk alleles and protective alleles. So this is a standard design that has been now used for a variety of different phenotypes over the last 15 years. And with this design, thousands of different GWAS loci have been discovered for different complex traits. And usually these loci have, again, relatively small effect size on the risk of a given disease. That's the clinical significance of these individual findings has been kind of difficult to establish. So polygenic risk scores come in as a potential solution where they aggregate these small effects in a computational manner to produce predictors with much larger power to discriminate cases from controls or predict disease. So one other comment I want to make about the genetic architecture of complex traits in humans is that it is really very much trait specific and phenotype specific. And just to make this point, for kidney-related traits on the left-hand side, I show the Manhattan plot from a GWAS for estimated glomerular filtration rate and CKD. This is Matthias Wuttke's study from 2019 from Nature Genetics, depicting that, in this very large collection of individuals of over 1 million individuals, there are multiple genome-wide significant loci being discovered. But overall, the variance explained in the estimated glomerular filtration rate is relatively low. So individual, again, these loci provide relatively small prediction of renal function and CKD risk. In contrast, the phenotype definition of membranous nephropathy, which requires a kidney biopsy, this is a primary form of glomerular disease that is obviously autoimmune mediated disease. And a GWAS study in a much smaller cohort of 3,000 cases and 9,000 controls uncovers only 4 genome-wide significant loci, but these loci have relatively large effect size on the disease risk, and they together cumulatively explain roughly 30% of disease risk. So obviously the phenotype definition really matters, and a different way of polygenic risk score modeling is required to capture these different types of findings. So perhaps the GWAS for EGFR requires more of a genome-wide approach to capture all of these small effects across the genome. Perhaps a GWAS for membranous nephropathy to model nephropathy risk requires more targeted approach, where on the top genome-wide significant loci are actually modeled for the prediction of risk. So next, I would like to go over some basic definitions in the field of polygenic scores. The first definition is that of genetic risk score. So here I'm showing a graphic of a Manhattan plot. On the x-axis, we have chromosome location. On the y-axis, we have level of statistical significance. This is kind of a typical Manhattan plot. Each dot represents a common variant across the genome. Let's just assume there are 10 million variants on the plot. And typically, a genome-wide significance threshold is used to declare genome-wide significant loci. That threshold is accepted to be 5 × 10⁻⁸ in terms of the p-value. So in this case, there are 3 genome-wide significant loci. And so one potential way to formulate a risk score, and that is the GRS, is to sum up the SNPs or risk alleles at these genome-wide significant loci, only concentrating on the significant loci, and perhaps capture their effects as well through a weighted sum of these SNPs or risk alleles, with the weights being effect sizes that are derived from the GWAS summary statistics. This risk score then can be further standardized by comparison to an ancestry matched controls by deriving mean and standard deviation of the control and performing a z-score transformation to express it in the units of standard deviation. So when cases and controls, when the risk score is actually graphed as a distribution, if the risk score is performing well, it will be shifted for the cases towards higher risk, as you can see in the graphic on the right. And the degree of shift is, of course, reflective of the discriminative ability of the risk score. And based on these distributions, a certain threshold can be selected for estimation of the risk. So as an example here, the z-score of 2.5 translates into the tail odds ratio of roughly 2, so 2-fold increased risk for individuals that are in the upper tail of the risk score distribution with z-score over 2.5. So this approach is suitable for modeling some traits, like, for example, membranous nephropathy would be a good example, but it has limitations. And one of the limitations is that you're capturing only genome-wide significant effects using this approach. And the ability to discriminate cases from controls is really very much limited by the sample size of the discovery GWAS. And so is your ability to actually detect and define genome-wide significant loci. So as an alternative approach, this way of modeling has been expanded genome-wide to formulate genome-wide polygenic risk scores. And just going back to this Manhattan plot, this method captures all of the SNPs, all 10 million SNPs across the genome, and sums them up, also as in the format of a weighted sum, where the weights are provided by the estimated effect sizes. It's standardized pretty much in the same fashion, but now you also need to account for non-independence of the SNPs across the genome, since of course they come in linkage disequilibrium blocks. So there are various methods that have been developed in the literature to account for linkage disequilibrium. This includes p-value thresholding and LD pruning methods, as well as more sophisticated regression-based methods that can account for non-independence. I'm not going to go through the details here because this area is actually an area of active development in the field of risk modeling, and there are new methods also that are entering the field as we speak. Finally, I want to introduce the concept of an integrated genomic risk score. An integrated genomic risk score is the idea of combining three different elements of risk. Two of them represent inherited risk. First is the polygenic component, that is the polygenic score, either GRS or genome-wide polygenic score. And that risk element is then combined with presence of Mendelian variants that can be relevant for the trait of interest. And then that information is further combined with the presence of traditional risk factors, such as positive family history for kidney disease, age, sex, smoking history, or whatever else is relevant for a given trait of interest. Admittedly, there are not that many examples of clinically useful integrated genomic risk scores right now, but one example that I want to bring up outside of the kidney field is the example of Bodicea, which is an integrated genomic risk score for breast cancer that has been published a couple of years ago, and it's an extremely promising tool that is undergoing clinical implementation. That risk score integrates a GRS based on 313 SNPs that have been discovered in GWAS for breast cancer with pathogenic variants in known breast cancer related genes such as BRCA1 and BRCA2. And additional well-established, more recently discovered genes, as well as traditional risk factors, including family history for breast cancer. And so this approach is really offering promise to further refine and enhance disease risk prediction. Hopefully, similar approaches will be developed in the kidney disease field. So next, I want to mention some of the reporting guidelines that came out recently for the PRS development. These guidelines were provided by ClinGen. That is a consortium that actually is involved in developing guidelines for proper interpretation of genetic predisposition to disease and also genetic variation. So ClinGen has taken this on because they've noticed the promise of polygenic risk scores, but also a great variability in the way that polygenic risk scores are being reported in the literature. So in order to systematize the reporting and establish certain standards for PRS interpretation and also implementation and clinical practice, they recommended very specific stages in the development of PRS and related reporting elements. So obviously, the development of polygenic risk scores requires robust GWAS, large enough to discriminate cases from controls. These GWAS summer statistics are used to develop the polygenic risk scores, but in order to develop the risk score, an independent optimization data set is needed. And that optimization data set needs to be well phenotyped for the trait of interest in order to select the best equation, considering that there are multiple different methods to develop PRSs. So with this first step, a PRS is being developed and the best score is being selected for a trait of interest. Again, different traits will require different methods to model the actual polygenic risk. And almost certainly after this step, the risk score will be actually overfitting. So we'll be overperforming. And so the second stage that is really critical is an independent validation stage. That the validation stage also requires a well-phenotyped independent data set. And based on the validation data set, a set of metrics, standard metrics, can be derived to test the performance and clinical utility of polygenic risk scores. This includes things like observing risk score distributions in cases and controls, testing risk score calibration, risk score discrimination, and the risk score predictive ability with tail effects, for example. In order to support these standardized reporting of polygenic risk scores, polygenic risk score catalog has been established as well, similar to GWAS catalog, that catalogs all of the polygenic risk scores that are published and performs and kind of catalogs standardized metrics of performance as well as risk score equations themselves to enable reproducibility of these findings. So this is a resource, and last time I checked, there were over 2,000 risk scores that are present in the resource for over 500 traits, covering over 200 publications. So this resource is evolving rapidly, and new risk scores are actually being added weekly to this catalog. So next, I want to mention a major limitation of polygenic risk score, and that relates to an ancestry bias. So I think most people are aware that GWASs are very much biased towards participants of European ancestry. In fact, it's estimated that 80% of all published GWAS studies involve participants of European ancestry. However, Europeans, of course, make up only roughly 16% of the global population. So there's a big disparity in terms of what data is present and in the literature in support of genetic determination of human traits versus the composition of the global population. And this is well illustrated here in this graph that analyzes the percentage of Europeans among all GWAS published studies and compares it to the diversity of the global population. Well, this is important because it turns out that polygenic risk scores developed on GWAS summary statistics that are based on Europeans, that are well optimized in European populations, do not perform well in other ancestries. And you can see this is a study of the accuracy of polygenic risk scores that are developed in Europeans and then applied to other populations. And you can see that the accuracy of prediction dramatically decreases as you move to populations that are more distant from the ancestry perspective from the Europeans. The poorest performance of the risk scores that are developed in Europeans and actually African ancestry populations. So this is a major problem, especially for clinical application of polygenic risk scores in more diverse patient populations, such as in the US. So one might ask why PRSs transfer poorly between ancestries. Well, of course, one explanation for this is that GWAS systematically favors variants that are common in Europeans just because of the skewed representation of Europeans in GWAS. But this actually extends beyond just the presentation of patients in the existing GWAS studies. This bias also involves early array designs, which were also biased towards European variation, as well as imputation panels, which were less diverse in the past. And that actually has changed more recently. They're more diverse and in an effort to kind of eliminate this bias, but some of the earlier GWAS studies are still profoundly affected by these design considerations. Secondly, the environment and demographics actually differ between populations. So this might drive differential forces of natural selections that in turn drive the differences in the causal genetic architecture of the disease. And a perfect example of this is APOL1 risk genotype, which is present exclusively in individuals of African ancestry. So this particular risk genotype would not be detected as a risk locus in GWASs performed in Europeans. It will be completely missed. And then finally, even when the underlying causal variants are the same, the differences in linkage disequilibrium between different populations will differentiate the estimates of SNP effects between populations. The SNP effects that are captured by polygenic risk scores. So the decrease in performance across ancestries is expected, but that doesn't necessarily mean that the risk scores developed based on European GWAS would not perform well in other ancestries. I think this really highlights the fact that it's necessary to validate PRS performance across different ancestries in order to properly implement the PRSs for clinical performance, and in order to enhance the interpretation of the risk score result that is being provided to individuals of diverse ancestries. So I just want to mention a couple of landmark papers that created a lot of excitement in the field of polygenic risk score modeling in terms of potential clinical applications. And both examples, I'll use coronary artery disease. The first paper was published in Nature Genetics in 2018. It's a paper by Kara et al. That looked at the polygenic risk score, actually genome-wide polygenic risk score for coronary artery disease. And this graphic demonstrates a distribution of the polygenic risk score in the testing data set of half of UK Biobank. And you can appreciate that the top 8% tail of the GPS of the genome-wide polygenic score is associated with over threefold increased risk of coronary artery disease based on this study. Well, this threefold effect estimate is important because it is pretty well established that familial hypercholesterolemia mutations confer roughly the same degree of risk when, obviously by increasing cholesterol levels, there's roughly threefold increased risk of coronary artery disease, but the population frequency of these Mendelian forms of disease are estimated at roughly 0.4%. So capturing 8% of population that is at equivalent risk to the Mendelian disease is very significant for perhaps population screening purposes and also for potential intervention. The second important paper I want to mention is that polygenic risk score could potentially modify the penetrance of monogenic variants. And just sticking with the CAD example, here's the effect of polygenic risk score as a function of being a carrier for familial hypercholesterolemia. And you can see that the carriers of familial hypercholesterolemia variant have a spread of risk that is dependent on the percentile of polygenic score. And in fact, individuals with low polygenic score, even though they might be carriers of familial hypercholesterolemia variants, might have risk that is comparable to non-carriers with high polygenic risk score. So polygenic risk score could be also very important in the interpretation of genetic tests for monogenic forms of disease. And it seems like the penetrance of monogenic familial hypercholesterolemia is at least partially explained by polygenic component. So finally, in the last part of the talk, I wanted to mention the work that we've done on modeling polygenic risk for chronic kidney disease specifically as it relates to nephrology. So this is the work performed by Atlas Khan, who's a PhD scientist and computational scientist in my lab. And this work was performed in collaboration with the Electronic Medical Records and Genomics Consortium. So Atlas has modeled the polygenic risk score for CKD using GWAS for estimated glomerular filtration rate. This is Dr. Wuttke's study of over 1 million individuals. And he has modeled the risk using UK Biobank as an optimization data set to derive multiple different scores using different methods. He selected the best score based on that data set. And then given the fact that the GWAS for EGFR is predominantly done in Europeans and it misses things like APOL1 effects, we specifically modeled the addition of APOL1 into the risk estimate and into the risk equation. And this was done using an African ancestry group of patients included in a UK biobank. And then we tested this risk score across multiple other biobanks, and we tried to optimize the ancestral diversity of the testing cohorts to demonstrate that this risk score is actually performing well across different ancestral groups. This is this formulation of the risk score that we ended up using based on the optimization data sets. Again, the polygenic component was derived based on GWAS for EGFR from 2019. This score was standardized. And then it turns out that based on the optimization data set of African ancestry, one standard deviation of that polygenic component, polygenic risk score, was roughly equivalent in effect of in risk effect to the recessive risk genotype for APOL1. So we basically formulated the equation where we standardized the genome-wide polygenic risk score, and we added one standard deviation if APOL1 risk genotype was present. We tested this in a testing cohort with the outcome of CKD stage 3 or higher, and we used covariates of age, sex, diabetes, and genetic ancestry. And you can see here in this plot, similar to the modifiers of the monogenic forms of disease, polygenic risk score appears to modify the effect of APOL1. This plot is based on 15,000 African Americans included in this study that were meta-analyzed across different cohorts. And you can see that the risk among those that carry the APOL1 risk genotype increases as a function of quantile of the genetic risk score. And it increases both in those with APOL1 risk genotype and without APOL1 risk genotype. The effect seems additive, and there was in fact no significant interaction between the polygenic component and the APOL1 risk genotype. Finally, we looked at the tail discrimination by different cutoffs of the top tail distribution of the polygenic score. And here I'm depicting the effects for the top 5%, top 2%, and top 1% of the polygenic risk score distribution, and that includes APOL1 by ancestry in independent testing cohorts. And you can appreciate that for most parts, the very extreme tail of the distribution, the odds ratio for these individuals exceeds threefold increased risk, which is roughly equivalent to the risk of kidney disease in those that have positive family history. So we feel that this might be a helpful tool for risk score stratification, at least the identification of individuals in the top 2% of the risk score distribution could be potentially used to enhance screening for kidney disease, as these individuals have markedly increased risk of kidney disease, similar to those that have positive family history. So this work was done in collaboration with the Electronic Medical Records and Genomics Consortium. And the nice thing about the consortium is that in phase 4, the consortium actually prospectively recruits 25,000 participants of diverse ancestries across multiple centers in the US. And the polygenic risk score for CKD was implemented as one of 10 risk scores that will be calculated for these individuals, and the results will be returned with prospective collection of outcomes. So we are very much looking forward to the results of this study. The results should become available in 2025 to see if the polygenic risk score for CKD can indeed enhance screening for CKD, if it can enhance detection and promote perhaps early interventions such as lifestyle modifications and adherence to frequent CKD screening. So in summary, I hope I convinced you that polygenic risk scores offer a promising new tool for risk stratification. They appear to also modify the penetrance of monogenic diseases. APOL1 risk genotypes and polygenic determinants of renal function appear to have additive effects on the risk of CKD. And the top 2% of the polygenic score for CKD appears to convey a threefold higher risk of kidney disease across ancestries. And this is roughly equivalent to a positive family history of kidney disease. And the clinical utility of polygenic scores is currently being tested in prospective studies. Thank you for your attention. I'll turn it over to Matthias now to provide his perspective on the polygenic risk scores and their applications in nephrology.
Thank you very much for the opportunity to talk about the role of polygenic risk scores in nephrology. I've got nothing to disclose. Clinical risk prediction means estimating the risk of individual persons for disease development or progression. This is not only very important for clinical decision-making, especially for early disease detection and prevention, but also as a tool for personal health management. Today, clinical risk prediction is mainly based on classic demographic parameters, such as age and gender, lifestyle factors, such as BMI, alcohol, or smoking status. Furthermore, it includes measurements such as blood pressure and biomarkers such as creatinine. Often, the biomarkers are closely related to the disease and near disease onset. Usually, a routine genetic profiling is not part of the clinical risk prediction, with notable exceptions, for example, in oncology. In nephrology, there's the well-established KFRE equation, the kidney failure risk equation, that predicts progression to kidney failure using the four variables age, sex, GFR, and UACR. Disease prevention is fundamental to advance human health. Genetics risk estimation is the earliest measurable contributor to heritable disease risk. In theory, genetic profiling is a useful component of health management. Recent studies on a subset of common diseases, such as coronary artery disease, used polygenic risk stratification to link these polygenic risk predictions to clinically actionable outcomes. In combination with classic risk factors, polygenic risk scores promise to help prioritize interventions and screening, to predict disease onset, and to identify groups with the greatest benefit of lifestyle modifications. A classic risk prediction model used in nephrology is the kidney failure risk equation, KFRE. In its basic form, the equation used the four variables age, sex, GFR, and UACR, and gives the risk of progression to kidney failure. My sample patient female is 74 years old, has a GFR of 54 and a UACR of 38, and she has a 5-year risk of 0.43% to reach kidney failure. To put this into some context, in the US, only 3% of the people with CKD experience kidney failure. In nephrology, there are large-scale genome-wide association studies of kidney function, such as those from EGFR. These results enable the generation of powerful polygenic scores. These GWAS are based on data from mostly population-based studies. Therefore, we asked two questions. If, in a CKD cohort, a population-based PGS for lower EGFR is 1. Associated with adverse outcomes, including kidney failure, and 2. Able to add to the predictive ability of adverse outcomes beyond established risk factors, including EGFR measurement from a single time point. In brief, we used the following procedure to develop and validate the PGS. We used publicly available data from 321,000 UK biobank participants of European ancestry and randomly split them into 90% and 10%. Together with the results from the CKD Gen Consortium, an international collaborative effort to investigate kidney function, genetics, and health and disease, multiple candidate PGS were built. These PGS were validated in another 10% European ancestry participants of the UK biobank. The resulting PGS was then applied to a CKD cohort, the GCKD study, also with European Ancestry participants. GCKD, the German Chronic Kidney Disease Study, is a prospective cohort study of 5,217 participants. They all have moderate CKD. Their EGFR on baseline range between 30 and 60. Follow-up since 2010 is still ongoing. We evaluated 3 prospective outcomes: dialysis, kidney transplantation, or death due to foregoing dialysis, KF, acute myocardial infarction, cerebral hemorrhage or stroke, 3-point MACE, or overall mortality death. To investigate the association of the PGS with these outcomes, we used Cox regression models to determine cause-specific hazard ratios. The base model included the PGS as a continuous variable, sex, age, baseline EGFR, and genetic principal components. We found significant associations with all 3 endpoints. Over the time of follow-up, 6.5 years, the risk of kidney failure was 1.22 times higher per 1 standard deviation higher polygenic risk score. This slide shows associations of the PGS quartiles with different endpoints. Quartile 1 was set as the reference. The colors represent the different endpoints. Solid lines show associations of the base model, sex, age, EGFR, and principal components. Dashed lines represent the extended model that adds history of cardiovascular disease, diabetes, log UACR, smoking, systolic blood pressure, use of blood pressure medication, CRP, high-density lipoprotein, and stars mark significant associations. This red bar here shows the association of the PGS with kidney failure. The hazard ratio is 1.78. That means individuals who have a PGS in the 4th quartile have a 1.78-fold higher risk of developing kidney failure over 6.5 years as compared with the individuals in the 1st quartile. If we look at more extreme PGS scores, the hazard ratio increases. For example, individuals in the 1st decile, the top 10%, compared with the bottom 10%, have a more than 2-fold higher risk. This is a cumulative incidence plot. It shows the incidence of an adverse event, in this case kidney failure, over time. The differentiated lines represent individuals with the different quartiles of the PGS. At the right, you can see the difference of kidney failure probability between Q1 and Q4 of the PGS. The absolute risk after 6 years increases from 8% to 14%. This plot shows the prediction error of the different models over time. The prediction error can be used to see if the addition of a variable to a model leads to an improvement in that model. In that, the model can predict endpoints better with a new variable. The colors and shades represent the different models. Comparing the null model with the extended model, one can see that the prediction error decreases over time. So the added variable in the extended model leads to a better prediction of kidney failure. Interestingly, adding the PGS to the extended model does not lead to a further reduction of the prediction errors. Furthermore, adding the PGS to the null model, not containing any covariables, does not improve the null model. This is a receiver operating characteristic, ROC curve, after 6 years. This curve illustrates the diagnostic ability of a binary classifier system, as its discrimination threshold is varied. In other words, you choose a 1 minus specificity value, a false positive rate. The more false positives you accept, the better gets the sensitivity, the detection rate. A model with a higher area under the ROC curve, ROC, is better as you get more sensitivity for the same specificity. In this case, the ROC curve does not significantly improve when adding the PGS to the extended model. Thus, adding the PGS to the prediction model does not reduce the prediction error. How can this be? What can we learn from these data? A genetic readout of EGFR, thus genetically determined GFR, is associated both cross-sectionally with the presence of CKD, as has been shown by Krzysztof Kiryluk and others, and prospectively with the adverse outcomes kidney failure, 3-point MACE, and death. This underscores the importance of genetic variation for the development and the presence of chronic kidney disease. EGFR as a biomarker alone is associated with CKD progression. UACR is a second biomarker that's also associated with CKD progression. We now know that the risk score is also associated with CKD progression, both in the general population and in a CKD cohort, even after adjusting for EGFR, as I just have showed you on the slides before. Yet, this score does not add predictive ability above and beyond the KFRE, as the KFRE already incorporates EGFR and thus captures the same information as the PGS. This is not too surprising. It is still worthwhile to investigate this because the PGS as a lifelong exposure may better capture risk than the cross-sectional measurement of EGFR. We need to take into account that significant associations are a prerequisite for prediction, but significance alone is not sufficient to achieve predictive ability. Significant associations do not necessarily translate into predictive ability. Taken together, I showed you one specific example for clinical validation of a PGS with prospective outcomes in a German chronic kidney disease study that Krzysztof Kiryluk was referring to in his talk. I have showed you that the PGS cannot be used to predict progression to kidney failure in a CKD cohort. Can use it and other PGS as a screening test. That means to predict disease status cross-sectionally in the population. As an example, one could think we can use a PGS which can theoretically be computed already at birth to predict if somebody will get CKD later in his or her life. This curve here shows the detection rates, sensitivity, by the odds ratio between the highest 20% and the lowest 20% PGS risk groups for a common disease. Assume that the relative risk of disease is twice as high if a given person is in the top 20% of a PGS. This leads to a detection rate of 10%, as can be seen from this left graph, which means we only find 10 affected individuals out of a total of 100 affected individuals. Thus, we miss 19 of 100 individuals. If you compare this to other screening tests, this is really poor. In order to be useful for screening, the relative risk must be extremely high between marker and disease. For a detection rate of 90%, we have a relative risk of more than 10,000 between marker and disease. This means we cannot use a PGS alone to detect individuals that are going to be affected by CKD. So what can we expect from a PGS? A theoretical limit to what a PGS can predict is the heritability. This is defined as the proportion of phenotypic variance that is explained by additive genetic variance, such as the proportion of EGFR variance that is explained by mostly common genetic variance. A PGS can, by design, only predict variance that is heritable. Here's one example from the great review by Torkamani et al. That I found particularly useful. BRCA1 and 2 variants have a prevalence much lower than 1%. So these variants explain only a small fraction of breast cancer heritability at population level. But in different words, the total incidence of breast cancer attributable to BRCA1 2 variants is low. Yet, for a given BRCA1 2 positive female, these variants confer a substantial absolute lifetime risk of breast cancer, a risk that is much higher than the risk for breast cancer in the general population, which is approximately 12%. This BRCA1 2 example illustrates that even in a setting where a PGS explains only a small part of disease incidence, is still very useful. One needs to pay attention to the difference between heritability in a population and risk conveyed to an individual. PGS as a risk factor. We already know for some common adult onset diseases that for up to 10 to 20% of a population, the magnitude of risk conferred by a PGS is comparable to classic risk factors or family history. Thus, it makes sense to use PGS together with and similar to classic risk factors. PGS can enhance risk stratification of a population so that preventive interventions that have risks and benefits can be targeted in a more effective manner. On the left, you see the 3 classic CAD risk factors: cholesterol, smoking, and high blood pressure. If you add a PGS for a CAD, you arrive at a combined risk. Taken together, the absolute risk for a CAD can surpass a given action threshold, which may then have a clinical meaning or prompt certain actions. 2 models that have the same ability to discriminate, such as Model A and Model B in this figure, can still be very different in terms of risk prediction, looking at single individuals. Model A and Model B discriminate the people equally well. Both models order the 5 diseased people in the same way and have 4 people above average risk. Both models share the same receiver-operatic risk curve, ROC curve, but the distributions of the risk scores are different. This one person on the top can have such a high risk that he or she belongs to the very high risk group and thus qualifies for an intervention. Now I show you that it provides a benefit to stratify individuals using their genetic risk scores. The first example of a PGS for coronary artery disease and statin treatment illustrates the number needed to treat for individuals with different PGS risk score categories. In the top area, you need to treat 20 persons for one person to have a benefit, while in the lower area, you need to treat 60 persons for one person to have a benefit. This is similar for breast cancer screening. Thus, in total, knowledge of the PGS class of an individual reduces the number of individuals needed to treat or to screen. While causal risk variants are often shared across ethnicities, polygenic risk variants at the heart of the GPS are dependent on ancestral composition. As Krzysztof already pointed out, portability across ethnicities is a very important research topic. Physician and public education regarding the interpretation of GPS is very important. Early commercialization might have already led to a negative bias. For efficiency reasons, one should not only use the GPS to recommend earlier prophylaxis or interventions, but also give advice against early screening for the individuals in the lower risk categories. This is more challenging. A careful communication strategy is important to avoid a negative psychosocial impact, such as the assignment of a high-risk status leading to anxiety, or vice versa, conveying a false sense of security to individuals in low-risk groups. To summarize, the PGS for EGFR is associated with CKD and other adverse outcomes, both cross-sectionally and prospectively. It was not useful for prediction of CKD progression. In general, PGS cannot be used as classic screening tools. Yet they are useful as risk factors to stratify risk and disease susceptibility and can inform clinical decisions. With this, I'd like to thank Anna Köttgen for being a fantastic mentor. Inga Steinbrenner performed many of these analyses and did most of the plots that I showed you today. I acknowledge the work of the PGS group and thank you very much to the GCKD study and all the patients supporting science via the CKD consortium with all participating studies, the UK Biobank and the funding agencies. Thank you very much for your attention. Now we are open for discussion.
Okay, thank you very much for those presentations. Now we'll move into the questions and answer period.
Krzysztof, are there any promising therapies based on potential genetic risk through GWAS analysis?
Yeah, this was one of the questions that was brought up by the audience, and currently we don't have therapies that are using polygenic risk score information, but I think this is a very important area that requires future studies. The question really is, are patients who are at high polygenic risk of kidney disease or any disease for that reason have different response to treatment? And I think we really need well-designed trials to answer this important question.
I mean, in other areas, there's like first ideas and first applications of PGS to modulate therapies. But in nephrology, I think we are right at the beginning. And I think it's an exciting field where we will see new studies and maybe potential applications.
It's also refreshing to see that the pharmaceutical companies are now including genetic profiling as part of a lot of their clinical trials. And some of the subgroup analyses could be done on existing clinical trials for various treatments, assessing responsiveness to treatment based on polygenic risk score or genetic information. We received another question from the audience, and that is, do you see a potential role for PRS and congenital anomalies of the kidney and urinary tract, since specific phenotypes are often relatively rare and GWAS had limited success in this area so far? Matthias, do you want to comment on this?
Yeah, of course. So, I mean, that's absolutely right. So GWAS have been difficult with CACUT And I guess, of course, there's a large role of monogenic mutations in that field. So for sure, there's a lot of genes that have been discovered in pediatric nephrology for this topic. And of course, it's hard for GPS based on common variants to predict such of CACUT. And I guess there might be some modulating, as Krzysztof pointed out in his talk, of the penetrance of these monogenic variants through PGS. But as already has been speculated in the question, it's hard as we don't have well-powered GWAS and many significant results for CACUT.
Yeah, and I completely agree. You know, this gets to my earlier point that the genetic architecture of the trait is really trait specific. And for CACUT, at least, it seems like the phenotype is really enriched in monogenic causes and also copy number variants. And of course, these are not captured by polygenic predictors right now. And if there are no GWAS studies for CACUT demonstrating that polygenic, common variants have an effect on the phenotype, then really we don't have tools to address this question. My suspicion is that the monogenic component will dominate in CACUT.
No, absolutely. So then we received another question about the ancestry composition. Are PGS applicable to South Asian populations?
Yeah, that's an excellent question. So South Asian populations are traditionally understudied in GWAS. We really made an effort to gather a South Asian ancestry testing cohort that was included in a validation of our GPS for CKD. And in fact, the risk score performed well in that group of individuals. These were defined as subgroups of UK Biobank and subgroups of individuals enrolled in eMERGE, so multi-ethnic cohorts that were South Asian individuals defined genetically. So it seems to be translating to that particular population, but I think there is definitely a need to include more South Asian individuals in GWAS studies to improve prediction.
Yeah. Thanks. I think that points a bit to the biggest limitation of the PGS as they are right now, and as we already also pointed out during our presentations, the transferability of the PGS across ethnicities, right?
Yeah, and I think the big question is how can the current polygenic risk prediction be improved in the future? What is the next generation of polygenic risk scores that will improve some of these performance issues with across different ancestries? And I think the answer is that we really need to integrate GWASs across all of these understudied populations in a meaningful way in order to improve risk prediction, polygenic risk prediction in these global populations. Fortunately, I think more data, GWAS data is on the horizon. I know CKD Gen is expanding. All of us has just released, a sizable data set that is enriched in diverse ancestries. And there's an effort in general by the genetic community to increase diversity in GWAS studies. And I think this is already happening. So I predict that next generation of risk scores will incorporate some of the understudied populations, and also perhaps other phenotypes that are not only limited to estimated glomerular filtration rate, but maybe albuminuria and maybe some of the risk prediction for primary kidney diseases that are biopsy defined as well. But Matthias, I would be interested in your thoughts as well.
Yeah, I completely agree. So I think it makes very much sense to team up in the research community to perform even larger studies, to have trans-ethnic studies that include data from as much ancestries as possible, to sort of remove this European ancestry bias we right now have in our studies. I think that's urgently needed. And as you have already said, Krzysztof, that's something that's hopefully happening soon.
Yeah, even thinking about African American populations that are included in our eMERGE studies, there is still much improvement in terms of modeling risk in that population. We had 15,000 individuals in the validation cohorts. It was still a relatively limited sample size compared to all of the other populations. We need bigger, better studies. There are other variants that have been established as risk variants for kidney disease and African ancestry, like sickle cell trait, that are currently not captured by the risk scores. So there's still a lot of improvement to optimize the risk scores for that particular population.
And then I think coming back to nephrology, that's also very important for us to really have a look at our diverse and interesting phenotypes and maybe go there into more detail. We now have data on EGFR, and there's emerging evidence on UACR that's going to be better in the future. I think there will be more associated regions appearing, hopefully. And then I think maybe at one time we are there that we can also have closer looks at different etiologies of CKD. I mean, with the membranous nephropathy, that's an excellent example where this works very well, but that may also work better with different etiologies, given increasing sample sizes.
Yeah, and of course, validating the polygenic risk scores in prospective studies, such as, the data that you presented was really interesting, looking at the development of kidney failure as a function of polygenic risk score in a prospective fashion in the German CKD study. That was extremely interesting, and I think we need to see more testing of polygenic predictors in the prospective data sets. And of course, these are harder to come by, and there are not that many well-established prospective kidney studies that are diverse enough as well. So that includes all of these different populations.
Yeah. And well, it really struck us to see that this GPS was really not, this one particular GPS was not really adding too much predictive ability, despite being associated. So, I mean, that's something that really warrants further investigation, maybe with a bigger study or a wider inclusion criteria for the follow-up of these prospective patients or individuals. Thank you very much for listening to our webinar. It was really very interesting for us to prepare, and I hope you enjoyed it, and have a good day.
On behalf of our audience, I want to thank our presenters for great presentations today. And thanks to our audience for your submissions of questions as well as your attention today. Note this webinar was supported by an unrestricted educational grant from Natera. At this time, we will end the webinar, and you may now disconnect.